The story of the thyroid gland actually begins at the top of the endocrine hierarchy. The true command center isn't located in the neck, but at the base of the brain, just above the pituitary gland, in the hypothalamus. While the pea-sized pituitary gland, resting in the bony sella turcica, is frequently called the master gland, the hypothalamus is the one actually pulling the strings. It secretes thyrotropin-releasing hormone, or TRH, to dictate the pituitary's actions. Connected by the infundibulum, TRH travels to the anterior pituitary via the hypothalamic hypophyseal portal system, arriving undiluted. Receiving this, the pituitary secretes thyroid-stimulating hormone, releasing it directly into general circulation to seek the thyroid gland. That isolated, undiluted portal connection is the necessary biological hardware. Without it, the brain could not exert the precise top-down control required to manage the body's entire metabolic engine. This image is a planar thyroid scintigram showing the physical outline of the gland. A normal thyroid weighs between 15 and 20 grams. It wraps around the trachea just inferior to the larynx, consisting of a right lobe, a left lobe, and a narrow bridge called the isthmus. Notice how the right lobe is often anatomically larger than the left. There is an important anatomical variant called the pyramidal lobe. It is an embryological remnant that typically extends superiorly from the isthmus. While structure present in roughly two-thirds of people, it is only visible on standard diagnostic imaging in about 10% of cases. The thyroid migrates downward, creating the thyroglossal duct. Ectopic tissue may remain anywhere along this path: the lingual base, suprahyoid, infrahyoid, or the mediastinum. Ectopic tissue pelvis, known as struma ovari. Recognizing these unpredictable ectopic pathways is required knowledge for clinical imaging. If doesn't know where the tissue can hide, cannot accurately interpret whole body scans. The thyroid's manufacturing process relies entirely on raw materials from the diet. When ingested, iodine is absorbed in the duodenum and jejunum as the iodide ion. Absorption is highly efficient, reaching 90 to 95% bioavailability within 60 minutes. Once in the extracellular plasma, the free iodide circulates. The thyroid gland consumes about 30% of it. The remaining ions are either taken up by other tissues, like the salivary glands and gastric mucosa, or excreted primarily through the kidneys. Iodine arrives at the follicle lumen. On the outer basolateral membrane, the sodium-potassium ATPase pump maintains an active ionic gradient. This powers the sodium iodide symporter, actively co-transporting two sodium ions and one iodide ion into the cell simultaneously. This relentless active transport mechanism physically traps iodide, creating an intracellular concentration up to 500 times higher than the surrounding plasma. This microscopic ionic trap guarantees raw materials are exactly where they need to be, acting as the engine driving the synthesis of human metabolic regulators. Iodide crosses the apical membrane via pendrin into the colloid. Here, thyroid peroxidase, TPO, oxidizes it and incorporates it into a thyroglobulin scaffold, forming MIT and DIT. Finally, TPO couples these molecules to synthesize triiodothyronine, T3, and thyroxine, T4. These newly built hormones stay bound to the thyroglobulin scaffold until TSH signals their release. The follicular cells endocytose droplets of the colloid, break down the scaffold, and release free T3 and T4 into the bloodstream. The thyroid releases mostly T4, so peripheral tissues like the liver and kidneys remove one iodine atom to convert it into biologically active T3. To prevent overproduction, these hormones regulate themselves through a negative feedback loop. High circulating levels of T3 and T4 travel back to the brain and automatically suppress the release of TSH at the pituitary level, while low systemic levels prompt an increase. This self-regulating biochemical loop maintains strict physiological balance. It provides a precise, uninterrupted supply of these master hormones to fuel the rest of the body. Inside every living cell, there is a constant baseline pulse of energy. The speed of that pulse, your body's physical idle speed, is dictated by a molecular switch. This switch is driven by thyroid hormones, triiodothyronine, known as T3, and its precursor thyroxine, or T4. These molecules are the master modulators of the basal metabolic rate. Their primary physiological role is to set the rate of oxygen consumption and heat production. They effectively determine the speed at which the body's internal engine runs while at rest. The scale of this influence is total. From the density of bone structures to the formation of neural synapses, these hormones interact with virtually every cell type in the human organism. While the T3 molecule is uniform, its effects are not. It must simultaneously signal the heart to beat faster and the liver to break down fuel, requiring a mechanism that translates a single signal into many different outcomes. To understand how a single molecule governs such a complex system, we have to look at the mechanism of action, tracing the hormone from its microscopic receptor targets up to the macroscopic clinical results. The T3 molecule operates through a dual velocity system. It modulates cellular function via two distinct temporal pathways, a slow structural pathway and a rapid functional pathway. In genomic action, T3 enters the nucleus, rewriting DNA. A guard protein locks the thyroid receptor. T3 binds it, kicking the guard out. T3 pairs with RXR, recruiting coactivators to produce mRNA. This builds proteins like the sodium-potassium pump, driving metabolism. But protein synthesis takes time. For responses that cannot wait days, the cell utilizes phase 3, the non-genomic action, or the fast track. In this pathway, T3 and T4 bypass the nucleus. They bind directly to the mitochondria, the cell's power plant, telling it to burn more fuel immediately. These hormones also act on the cell membrane to instantly open ion channels. This accounts for rapid physiological shifts, such as a sudden increase in heart rate. Through this dual velocity system, the thyroid regulates both immediate survival responses and the long-term synthesis of new cellular machinery. Specificity of these organ responses is determined by which part of the DNA blueprint is accessible when the T3 switch is flipped. In the heart, T3 upregulates beta-1 adrenergic receptors and myocardial calcium levels. This creates a faster heart rate and a stronger, more efficient pump. In the liver and skeletal muscle, T3 focuses on energy breakdown. It stimulates gluconeogenesis to create glucose for fuel and promotes the development of fast-twitch type 2 muscle fibers. In the nervous system, the hormone is essential for myelination and synapse formation. It effectively sets the speed for reflexes, mood, and cognitive processing. Bone tissue requires T3 to work synergistically with growth hormone. This interaction drives linear bone growth in children and constant bone remodeling in adults. In white adipose tissue, the hormone stimulates lipolysis, breaking down stored fats into free fatty acids to be used as fuel for metabolic processes. This diagram compares white fat to brown fat. In brown adipose tissue, T3 activates specific uncoupling proteins within the mitochondria. This thermogenesis process causes mitochondria to bypass ATP production, instead releasing energy as pure heat. Finally, to support this load, T3 increases kidney filtration rates and enhances gastrointestinal motility, ensuring nutrients are absorbed and waste is cleared efficiently. While the molecular trigger is the same in every tissue, the localized genetic blueprints ensure that every organ responds in a coordinated tissue-specific manner. Because the system is so finely tuned, even small deviations in hormone levels force these cellular blueprints into pathological states. This creates two distinct clinical profiles: hypothyroidism, where the metabolic engine slows down, and hyperthyroidism, where it enters a state of dangerous overdrive. Cardiovascularly, low levels lead to bradycardia and decreased cardiac output. High levels cause tachycardia and palpitations, significantly increasing the risk of atrial fibrillation. Metabolically, a deficit causes weight gain and cold intolerance. A surplus leads to rapid weight loss, excessive sweating, and an inability to tolerate heat. Neurological symptoms range from brain fog and delayed reflexes in hypothyroidism to anxiety, tremors, and insomnia in hyperthyroidism. In the musculoskeletal system, Low levels cause muscle cramps and joint pain. Excessive levels lead to muscle weakness and decreased bone density, resulting in osteoporosis. Dermatologically, we see dry skin and brittle hair versus the thin, moist skin and plumber's nails associated with overactive thyroid function. Reproductive consequences are equally mirrored, moving from heavy or irregular periods on the low end to infrequent periods and decreased libido on the high end. Every symptom we observe clinically is the macroscopic result of these microscopic errors in cellular programming. When these imbalances go untreated, the metabolic shift can reach critical, life-threatening extremes. The end stage of hypothyroidism is myxedema coma. This is a state of total metabolic shutdown. It is characterized by severe hypothermia and hallucinations, eventually leading to a complete loss of consciousness. On the other side is a thyroid storm, a thyrotoxic crisis where the body's engine effectively overheats. This medical emergency presents with high fevers, often exceeding 104 degrees, extreme tachycardia, delirium, and potential heart failure. There are also developmental extremes. In infants, a congenital lack of thyroid hormone leads to a condition called cretinism. Without T3 to drive neurodevelopment, the result is permanent intellectual disability and stunted physical growth, highlighting the hormone's role in the very formation of the human body. Even in less extreme cases, diagnosis can be difficult. In the elderly, apathetic hyperthyroidism can mask the usual signs of overdrive. Instead of anxiety or a racing heart, these patients may present with lethargy and weakness, making the underlying thyroid issue easy to miss. Because the symptoms are so diverse and can often be contradictory, clinical observation alone is insufficient for a definitive diagnosis. Identifying these systemic shifts requires objective data. The biochemical truth of the body's metabolic state is found in a TSH and free T4 blood panel. The thyroid gland relies on a transmembrane protein known as the sodium iodide symporter, or NIS. This protein actively transports iodine from the bloodstream into the thyroid follicles to begin hormone synthesis. Nuclear medicine exploits this specific physiology for two distinct clinical functions. By attaching radioactive isotopes to molecules that target the NIS, physicians can map the gland's function for diagnosis or deliver targeted radiation to destroy diseased tissue. This integration of diagnostics and therapy defines the Theranostic Approach. The clinical outcome depends on the specific physics of the chosen isotope. The half-life, the type of emission, and the photon energy must be precisely matched to the biological behavior of the target tissue. To execute this, physicians rely on three primary radiopharmaceuticals: iodine-123, iodine-131, and technetium-99m pertechnetate. In thyroid oncology and endocrinology, a single cellular mechanism can be exploited for both surveillance and destruction. Here, understanding a cell's metabolic function provides the specific mechanism needed to manage its pathology. This matrix outlines essential thyroid radiopharmaceuticals, beginning with iodine-131. Its 0.606 megaelectron-volt beta emission travels a short distance to cause localized cellular necrosis. It also emits a 364 kiloelectron-volt gamma photon, which degrades image quality, limiting diagnostic applications to small doses. Once administered orally, about 90% of the dose is absorbed in the proximal small intestine within 60 minutes. It is excreted via the kidneys and GI tract, though transient non-thyroid uptake also occurs in the salivary glands, stomach, and choroid plexus. Using iodine-131 for imaging carries a limitation known as the stunning effect. This cellular sequence demonstrates why using the therapeutic iodine-131 for initial imaging is dangerous. A diagnostic dose of iodine-131 emits beta particles that physically damage the cell's surface NIS receptors. This creates the stunning effect. When the massive therapeutic dose is subsequently administered, it bounces off the disabled cell because the entryways have been destroyed. To avoid this effect, we shift to iodine-123. Featuring a 13.2-hour half-life, it decays via electron capture, lacking beta emissions entirely. It produces a 159 kiloelectron-volt gamma photon, making it the preferred agent for adult diagnostic scans. The third option is technetium-99m pertechnetate. Administered intravenously, it has a 6-hour half-life and decays via isomeric transition, emitting a 140 kiloelectron-volt gamma photon. Unlike iodine, technetium-99m is trapped by the NIS, but is never organified into thyroid hormone. Peak uptake hits between 15 and 30 minutes post-injection. Its fast imaging timeframe and low radiation profile make it a preferred choice for pediatric patients and lactating women. Finally, iodine-124 is utilized for high-resolution metastasis detection. With a 4.18-day half-life, its 511 kiloelectron-volt emission is captured via PET imaging, offering precise pre-therapy dosimetry. Selecting an isotope requires a trade-off. Physicians must weigh the clarity of the diagnostic image against the therapeutic payload and the risk of bystander toxicity. This graph illustrates the radioactive iodine uptake, or RAIU test, which measures global iodine metabolism. A normal subject shows a gradual rise, plateauing between 10 to 30% at the 24-hour mark. These RAIU percentages are a critical variable in Marinelli's formula, used to calculate individualized therapeutic doses of iodine-131. In Graves' disease, or diffuse toxic goiter, the gland exhibits highly elevated rapid uptake, frequently spiking to 50 or 80%. Conversely, conditions like subacute thyroiditis or fictitious thyrotoxicosis present with markedly suppressed or completely absent uptake. Scintigraphy provides a visual map of this function. Hyperfunctioning hot nodules are autonomous and rarely malignant. Hypofunctioning cold nodules carry a higher risk of malignancy and require further evaluation. Scintigraphy also helps locate ectopic thyroid tissue, such as lingual thyroids at the base of the tongue or substernal goiters extending into the chest. For deeper mapping, the potassium perchlorate discharge test identifies congenital organification defects, while the T3 suppression test helps pinpoint autonomous tissue or borderline Graves' disease. Dynamic functional testing maps these physiological pathways in real time, yielding metabolic information that static anatomical imaging cannot capture. For the definitive treatment of hyperthyroidism, iodine-131 is the cornerstone. In Graves' disease, the objective is gland ablation, resulting in manageable, permanent hypothyroidism. For non-toxic nodular goiters, iodine-131 can be used to shrink tissue and relieve compressive symptoms in patients who cannot undergo surgery. The mechanics are highly selective in toxic nodules. Iodine-131 accumulates in autonomous tissue, while suppressed normal tissue absorbs minimal radiation and can regain function later. Precision extends to differentiated thyroid cancer. Papillary and follicular cancers often retain the ability to concentrate iodine, providing a targeted pathway for treatment. Low activity is used for remnant ablation to facilitate monitoring of the tumor marker thyroglobulin. Higher activities are deployed as adjuvant treatments for metastases. Whole-body diagnostic scans are performed pre-therapy for staging and 3 to 7 days post-therapy to confirm the destruction of the targeted lesions. To maximize uptake, thyroid-stimulating hormone levels must be elevated, either by withdrawing hormone replacement or by administering recombinant human TSH. Before administering high activities for disseminated cancer, physicians use dosimetry to calculate the maximum tolerated activity. The goal is delivering maximum radiation to tumors while restricting the absorbed dose to blood and bone marrow to a limit of 2 gray. Lung retention must also be monitored to prevent pulmonary fibrosis. Treating differentiated thyroid cancer with iodine-131 is an exercise in physical precision, maximizing targeted beta decay while protecting healthy systemic tissue. Aggressive thyroid cancers can dedifferentiate, losing expression of the NIS importer and stopping iodine concentration entirely. The metabolic consequence of this mutation is immediate. To sustain its rapid, uncontrolled growth, the tumor develops an aggressive reliance on glucose. This side-by-side scan illustrates the result, known as the flip-flop phenomenon. On the left is a negative iodine scintigraphy scan, showing a complete lack of uptake. On the right, an 18F-FDG PET map glows intensely, revealing hidden, glucose-hungry metastases. This leads to tennis syndrome, where thyroglobulin is elevated but iodine scans are negative. In these cases, 18F-FDG PET-CT becomes the critical diagnostic tool. It uses tumor volume and lesion glycolysis as prognostic biomarkers for overall survival. Research into redifferentiation therapies uses drugs to stimulate recovery of the NIS importer in refractory cancers, potentially making them susceptible to iodine 131 again. To evaluate indeterminate nodules, physicians measure mitochondrial density using technetium-99m sestamibi. A lack of sestamibi retention has a high negative predictive value for ruling out malignancy. Medullary thyroid cancer arises from parafollicular C cells, which do not concentrate iodine. This makes standard radioiodine scans ineffective. Instead, physicians use tracers that target sympathomedullary pathways, such as MIBG, pentatriotide, or anti-CEA antibodies. PET-CT options include 18F-FDOPA and gallium-68 dotatate. For advanced cases, systemic treatments include high-dose MIBG therapy, or peptide receptor radionuclide therapy, utilizing beta emitters like yttrium-90 or lutetium-177. Palliative agents like strontium-89 can be used for skeletal metastases. At the extreme end of the spectrum is anaplastic thyroid cancer. It is highly aggressive and lacks both the NIS importer and thyroglobulin production. For this cancer, nuclear medicine is strictly diagnostic. 18F-FDG PET-CT is used for rapid initial staging and for monitoring the response to systemic therapies. As the pathology of a tumor evolves, the molecular targets change with it. Diagnostic tools must pivot to track the disease across its metabolic shifts. Clinical success in modern thyroid nuclear medicine strictly relies on perfectly matching isotopic properties to specific biological mechanisms. This ranges from using the clean 159 kiloelectron-volt emission of iodine 123 for diagnostic clarity, to utilizing the destructive beta emissions of iodine 131 for cellular ablation. When tumors mutate, imaging modalities must shift from localized scanning to the metabolic tracking of PET-CT for undifferentiated tissues. Calculating individualized doses and adhering to strict toxicity thresholds ensures that radiation delivery is optimized while protecting healthy bone marrow and lung tissue. The toolkit is expanding with tools like iodine 124 PET-CT for high-resolution dosimetry, and systemic alternatives like lutetium-177 and yttrium-90 for refractory disease. Nuclear medicine and thyroid care demonstrates a direct alignment between atomic properties and cellular function. By matching the isotope to the underlying pathology, physics provides a specific, individualized pathway for clinical intervention.